Now we're going to go talk about how this and this are related in a left AIC pattern. This is the diaphragm right here. So you're going to see that when my pelvic floor is descended, my diaphragm is also descended. And we're going to talk about that. So we need both of these to go up. There's loads of research, you guys. You're going to notice how we talked about yesterday during our treatment when we did our lab with the repositioning activity, that there is a breathing component with every exercise. And I want you guys to understand what is going on, not only with the diaphragm, but also with the pelvic floor, because they work hand in hand. So if you have someone that has pelvic floor dysfunction and they can't breathe, the two of them, you've got to be able to get your patients to breathe correctly with the diaphragm. A lot of research shows your pelvic floor is continually active during all phases of respiration, but it is the most active during mid and end phase of exhalation. They also found that the IOs and the TA contractions were more closely coupled with the pelvic floor, that a strong pelvic floor contraction, which is your ability for your pelvic floor to ascend, was also noticed to be the strongest with mid and end range exhalation. A lot of this research is done by Paul Hodges and Sanford, and it's all in the back of your appendix. All the research is back there. Your pelvic floor, the more voluntary muscle contraction you get with your abdominals, again, your pelvic floor muscle is active. So there's going to be a method behind our madness with why we want our patients to give us a long, forced exhalation, or why we have them blow up balloons. And this research found that as we inhale more through our mouth, and we get more extension, that creates more of a valsalva. And guess what? We get more external oblique contraction, rectus abdominis contraction, and our pelvic floor descends. There was one study with women who had not had children, and they had more stress urinary incontinence because they had overuse of external obliques and rectus abdominis. So we focus on more internal obliques and transverse abdominis as supported by evidence-based research. It's also found that decreased diaphragmatic motion, they had an increased descent to the pelvic floor, was noticed with patients that had painful patients with an active straight leg raise. Their pelvic floor isn't in the correct position. So we can take this information and you're going to better appreciate why there's a breathing component with your PRI activity. You can make that pelvic floor a lot more stronger and powerful by getting your patients to breathe. By teaching your patients how to squat in a gym, if they can learn how to inhale and squat down and open up a pelvic outlet, and exhale, come up. Why? Don't hold your breath and lift a weight and push out your pelvic floor. And you wonder why athletes have back pain.